Hello everyone, welcome to Pediatrics by Dr. Anand. Is my voice audible to everyone? Let's start this amazing class, my dear friends. Yeah, today was a little hectic schedule for me. That's why I did everything late today. I went to gym late and everything happened late today. I really apologize. My name is Dr. Anand. This is the beautiful, what do you call it, our YouTube channel where we're going to talk about cardiology, some amazing important points. And today we have a case presentation. Is my voice audible to everyone? Hello, 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 hello. Hello, Dr. Manish, Osama, Sona. Let's start this beautiful session, guys. My name is Dr. Anand. I've done my MBBS from Rajiv Gandhi University Health Sciences, and I've done my MD from Tirthankar Mahavir University. Also, at the same time, I'm assistant professor working in a medical college with some amazing, beautiful experience of teaching. Also, at the same time, we teach to beautiful UG, PG, and DM and MRCPCH students. Today's topic of choice is nothing but cardiology. And before starting any amazing segment, we always have a beautiful, amazing quote. And today's amazing quote is: you don't have to be great to start. You don't have to be great to start, but you have to start to be great. So that's a very beautiful quote, guys. Do you agree with this? Yes or no? Hello, Dr. Shubham. मेरा प्यारा शुभम मुझे मैसेज करा था, सर ऑनलाइन आ जाओ, जल्दी आ जाओ सर, मैं आ गया ऑनलाइन. So you don't have to be, guys, you don't have to be, great to start, but you have to start to be great. So like, just push yourself as much as possible. Just push yourself as much as possible, because I have told you so many times that you are the only architect of your life, and do something amazing about your life. Okay, life is really beautiful. जिंदगी भगवान की एक बहुत महंगी गिफ्ट है, so इसे वेस्ट ना करें, एंजॉय करें, खुश रहें और बहुत ही एंजॉय करें. Let's start this beautiful class, guys. Now, today is a case presentation. Today, as we all know, it is the last class of this week. So I have a case presentation part 2. Now, these are now today I'm going to ask some crazy tongue twisting questions. So let's see if you guys can answer. So hello, Dr. Osama. Can you please tell me how is this t-shirt? Dr. Shubham's favorite color, black. And Dr. Shubham told me to wear this amazing, beautiful t-shirt. So let me know how is this t-shirt. I just came back from gym and this is very comfortable texture. Actually, it's a cotton t-shirt. And I hope you guys have liked and loved that t-shirt. Yes. So case presentation part 2. Let's start this beautiful class, my dear friends. Point number 1, very important. So I'm gonna speak about a beautiful case. Listen very carefully, have a copy and a pen, and try to talk to me as much as possible. This session will be spoken in English and Hindi language for 30 to 40 minutes. हम आज के सेशन में case presentation की बात करेंगे, and you try to participate as crazily as possible. Okay. So good evening, everyone. So I'm presenting a case of 11 months old male patient, 11-month male patient named Anand, forced by birth order, born of a non-consanguineous marriage. Hindu by community, residing in New Delhi, bought by the mother, and informant actually is the mother. Okay, so now this baby, basically, which 11-month-old we had now. So if I have a question at 20 hours old baby, like imagine this baby at day 1 of life, 20 hours old baby, like in the history of presenting illness, if I talk about, when the baby was 20 hours old baby, he came with cyanosis and not able to feed well with increased work of breathing. Now this one line itself has a lot of differential diagnosis. The mother gives a history. When the baby was 20 hours old, or during the first day of the baby's life, the baby had cyanosis. The baby was not able to feed well with increased work of breathing. Okay, so there are a lot of crazy stuff in this one. Cyanosis, not able to feed, and whenever the baby feed, there is an increased work of breathing. Question number 1 which comes to my mind: which is the most commonest congenital cyanotic heart disease which can preset on day 1? Can anyone answer in the comment section? We have this beautiful, amazing answer. Can you please answer in the comment section? Yes, very good, beautiful people. Yes, Dr. Wafa, yes, Dr. Shubham, Osama, Karan, and Dr. Suman, yes. So which is the most common congenital heart, if anyone can tell me, which can present on day of life 1? Anyone with a best answer? Obviously yes. So Dr. Shubham is right. Dr. Shubham is giving heart is also beautiful, and tell the answer, bro. Yes, exactly. So the most commonest congenital heart disease on day 1 of life, of course everyone knows about it. It's a super specialty question. TGA with the intact ventricular septum, transposition of great arteries with intact ventricular septum. So this is it's like a case presentation. Okay, it's like a case presentation. And I'm asking you, this baby, 20 hours of life, came with cyanosis, came with cyanosis. So the most common cyanotic congenital heart at day one is, of course, yes, TGA, obviously, sir. Hanji, Dr. Osama, yes, TGA, obviously. But I have a next question. Can I say tetralogy of Fallot? What's wrong with TOF? TOF is also a cyanotic congenital heart, right? My question is, can the patient present at day of one of life as tetralogy of Fallot? Can anyone answer in the comment section, please? Dr. Suman, Karan, Osama, Sandesh, Indian lovers, can a beautiful TOF, tetralogy of Fallot, can present at day of life one? Because as far as I remember, tetralogy of Fallot also has pulmonary stenosis, and the patient can have cyanosis, right? So can I say that TOF could be an important cyanotic congenital heart at day of life one? Yes or no? Dr. Shubham, yes, bang on answer, very, very true. Because yes, the answer for this question is usually the tetralogy of Fallot, it presents late, okay? Tetralogy of Fallot, it presents late. Why, sir? Tetralogy of Fallot is a congenital cyanotic heart disease. Why should not I think of tetralogy of Fallot as my first differential diagnosis in the congenital cyanotic heart disease? Because the answer for this question is, in tetralogy of Fallot, you know, right? Like the components of tetralogy of Fallot. Can you please quickly tell me? Of course, we know it's a right ventricular hypertrophy. Of course, we know it is a ventricular septal defect. Of course, there is overriding of aorta. And what else we have? We have pulmonary stenosis. Or if more in depth and detail you want to know, then remember we have a progressive infundibular stenosis. Progressive as in it is slowly going to happen. Infundibulum, the part, one of the part of the pulmonary artery, we have a part known as infundibulum. In tetralogy of Fallot, yes, Dr. Amrit, very good, bro. In tetralogy of Fallot, there is a progressive infundibular stenosis. It takes time for the whole pulmonary stenosis to happen. So that's what, read this line beautifully. At birth, the amount of blood going to the pulmonary valve is not that severe to cause a failure or cyanosis. Do you agree with this line? At birth, the amount of blood going to the pulmonary valve basically is not that severe enough to cause a failure or a cyanosis. To say it as cyanosis, the patient should have a complete pulmonary stenosis. Yes or no? If there is a complete pulmonary stenosis, then the lungs are not available for the oxygenation of blood and the patient will have cyanosis. In tetralogy of Fallot, yes, it is a cyanotic congenital heart, but the beautiful answer is, sir, it is a progressive infundibular stenosis. That's why within 1 month of life or after few weeks of life, you can appreciate as a cyanotic congenital heart TOF, but not on day of life one. So two questions very beautifully we have understood. Question number one is that the cyanosis at day one of life, the answer was TGA. In the later period, baby having cyanosis, the answer is TOF. Has everyone crystal clear, beautifully has understood this part? Please say yes or yes, yes. Yes, perfect. Next question I have. Now I have some amazing question. Okay, the mother gives a history. The mother gives a history that, doctor, there is a history of suck, rest, suck cycle. Can you please elaborate? Can anyone beautifully elaborate what is the meaning of suck, rest, suck cycle? Yes or no? ये मतलब क्या है इसका? शुभम कह रहा है biceps. Biceps? तू इधर आ. This is my beautiful biceps. Today was my biceps and triceps. This one. Yes, exactly. Yes. Manish says, looking too good, sir. Thanks, bro. Thank you so much. And I have got a blue t-shirt also of pediatrics by Dr. Anand. That's also is very amazing. Monday I'll wear blue t-shirt. Okay. Yes. What is the meaning of suck, rest, suck cycle? The meaning of suck, rest, suck cycle is point number one. Baby suck the nipple. Baby suck the nipple and then the baby take rest. Baby become breathless. He start having perspiration, nothing but kind of a sweating over the forehead. Baby takes a rest. Again he suck the breast and again he take the rest. Are you understanding? Baby suck the nipple, he get breathless, he take a rest and again he suck the nipple and then take a rest. This is known as suck, rest cycle. Can you please, question number one basic question, suck, rest cycle is seen in which congenital heart disease? Can anyone answer in the comment section, please? Suck, rest cycle is seen in which congenital heart disease? Can anyone answer in the comment section? Yes or no? What do you think? Yes. Beautiful. So can I say in a case of tetralogy of phalate, like we say tetralogy of phalate, but the proper spelling is tetralogy of phalate. We have something known as a cyanotic spell or something known as a tet spell, very importantly. Yes, exactly. Yeah, and also the patient will have a suck rest cycle. So this is one thing, it is in tetralogy of phalate, right? Now the question is like, what is the mechanism of suck rest suck? Can you please tell me, like, if I give you two options, the baby sucking the nipple, getting breathless, getting sweating over the forehead, take rest, again suck the nipple, get breathless, sweating over the forehead, again take rest. Can you please tell me what does it denotes? Like my options are, does it denotes right atrial hypertrophy, or I would say right ventricular dysfunction, or a left atrial dysfunction, or a left ventricular dysfunction? Which dysfunction can we appreciate in the case of suck rest suck cycle? Can anyone randomly answer? Can anyone beautifully tell me the best answer? Which ventricle or atria dysfunction is there when there is suck rest cycle? Can anyone answer in the comment section, please? क्या है ये? Is it a right atrial dysfunction, right ventricle dysfunction, left atrial dysfunction, left ventricle dysfunction? Yes, anyone? Can anyone answer in the comment section? शुभम, क्या लगता है ब्रो तेरे को? ओसामा, इंडियन लवर्स, सुमन, मरियम, मुमताज, ओके, अपना शुभम, प्रिया, ग्रेस, ओके. Now listen very carefully. Now this is what the cardiology, today's cardiology class is all about. Number one, now listen very carefully. When the child suck, remember, number one, sucking is like a exercise. Sucking is like a exercise. It's like a work of breathing. It's like a exercise. Remember, for a baby, okay, sucking the nipple, it has to burn calories. He has to, do a lot of hard work to suck the nipple. When the child suck the breast, what happens? Sucking is an exercise for the baby. Okay, sucking is an exercise for the baby. It needs energy. It needs energy. So the child, in a case of tetralogy of phalate, as we know, there is already it's a congenital heart defect, no? So as the child needs energy, so the child becomes breathless. The child becomes breathless. I'll repeat again. In tetralogy of phalate, why do you see suck rest cycle? Because once the baby suck the nipple, sucking is like an exercise for the baby. The baby cannot do so much of work. It needs energy. So the child becomes breathless. So once the child becomes breathless, it is because of the LV dysfunction. Please remember, it is because of the left ventricle is failing. Okay, it is because of the left ventricular dysfunction. Remember that. Okay, please. Yeah, tetralogy of phalate is a RVH. I totally agree with you. But remember, the patient, it is basically suck rest suck cycle is like a left ventricle is failing to pump the blood into the aorta. The left ventricle has to pump the blood into the aorta, but left ventricle is not able to pump because of the VSD component. Are you able to understand? If this is a four-chambered heart, whatever blood is there in the left ventricle, there is a VSD, right? So because of this mixing of the blood, because of the left ventricular dysfunction, that's what the baby have a suck rest suck cycle. Please update in your notes, okay? And exactly why the patient will have sweating, why this sweating is taking place? Because naturally what happens now, sweating tells us that there is sympathetic overactivity. Now please remember, yes, Dr. Suman, you're right, there is a sympathetic overactivity. Why there is sympathetic overactivity in my body? Because of the metabolic demand, because of the increase in the metabolic demand. So this is a new chapter, okay? So please update in your notes. I'll repeat again. Why the patient will sweating? Sweating is like a sympathetic nervous system is getting activated. Why it is overactivating? Because of the increase in the metabolic demand of the body. Why there is a what you called increase in the metabolic demand? Remember one thing, bottom line, remember one thing. In the cardiac disease, we are studying cyanotic congenital hearts, right? In the cardiac diseases, muscle gets decrease oxygen supply naturally because of the mixing of the blood. A proper flow channel is not there. There is some mixing of the oxygenated and deoxygenated blood. So very importantly, the muscles get decrease oxygen supply, number one. To fulfill this demand, there is autonomic hyperactivity, there is sympathetic stimulation. So autonomic hyperactivity, sympathetic stimulation, and therefore there is increased sweating and increased tachycardia. Remember that, okay? This is really very important point. Yes, Dr. Ahana Thakur, good evening, my dear. Dr. Priya, exact, Priya is right. That's what. So that's the whole thing. That's the whole thing. There's a sweating and tachycardia. I'm repeating again. I'm repeating again for the last time. The question was, this is why this is the proper cardiac clinical question. Okay, if you get a, as a final year MBBS student, if you get a case presentation and you say that, ma'am, there was a history of suck rest cycle, you, ma'am will ask you why. What is the meaning of that? Ma'am, baby suck the nipple, he get breathless, start having perspiration, he take rest. Why the baby suck the nipple and start getting breathless? Because, ma'am, in a case of tetralogy of Fallot, sucking is like an exercise, and as we are dealing with a congenital heart defect, and as there's a mixing of blood, the baby needs energy, okay, to suck the nipple. So that's why that baby becomes breathless, number one, very importantly. And also there is a left ventricular dysfunction. There's a left ventricular dysfunction, very important, that you should know very importantly. Okay, and also very beautifully you need to know, yes, why the patient will have sweating, because sweating basically it tells us sympathetic overactivity. Why there is sympathetic overactivity? Basically to increase, because there is an increase in the metabolic demand of the body. Why there is metabolic demand decrease? Because in the cardiac disease, muscles get decreased oxygen supply naturally because of the mixing of the blood. The right ventricle, left ventricle, these muscles get decreased oxygen supply. उससे क्या होता है? To fulfill this need, to fulfill the problem of this decreased oxygen supply, there is autonomic hyperactivity, sympathetic hyperactivity, and that leads to sweating, or that leads to tachycardia. Okay, that leads to tachycardia in this case of. Has everyone understood this much? Yes or no? This is like little hi-fi. Okay, I hope you have understood. Dr. Suman, have you understood? Mariam, Ahana, Shubham, Priya, Manoj, beautiful people, beautiful, amazing people. Dr. Devashish, we have Monimala, Naskar. Yes, exactly. Perfect. Perfect. Put a like button. Have you understood? Okay. Now let's see how much you have understood. The next question I have is, what are the symptoms the child can present which can explain the increased pulmonary blood flow? Very beautiful question. Dr. Shubham, like imagine, okay, imagine we are discussing this case. Okay, imagine you and me are like sitting together. I am the examiner and you are the student. I'm asking you, okay, think, okay, open your brains. I'm asking, so what are the, so Dr. Osama, what are the symptoms the child can present which can explain increase pulmonary blood flow? Can anyone answer in the comment section, please? Dr. Muhammad Inam, yes. Okay, Pooja says infection. Okay. Faizan Raza, Osama, Priya, anyone? Yes, exactly. Yes, ABC is asking. We get online class every day, same time, Monday to Friday, 8:30 p.m. Monday to Friday, 8:30 p.m. is what we take the class. Okay, anyone? Yes, Dr. Awesome is right. Yeah, now you're speaking very smart. When everyone knows about it, we have discussed this multiple times. It's just a different way of asking it. This is the pulmonary artery, right? I am saying, what are the symptoms the child can present which can explain the increased pulmonary blood flow? Too much of blood is going in the pulmonary artery. So naturally, there will be, if there is an increased pulmonary blood flow, the patient will have increased URTI, increased LRTI. Exactly. Can I say the patient will have a repeated episodes of hospitalization? Yes or no? Very importantly, the patient is not gaining weight and not gaining height. That also is important. And the patient can present to you as FTT. And what is the meaning of FTT? Failure to thrive. Failure to thrive, right? Exactly. Very good, very good. Ganpati is right, Wafa Hussain is right, Osama, Faizan Raza, and our Shubham, amazing. Very good, very good. So these are the beautiful things of the increased pulmonary blood flow. So jitna zyada, the more the blood will go into the pulmonary artery, the patient will have URTI, LRTI, failure to thrive, increased precordial bulge, tachycardia, increased activity. That's very well put. Okay, now I have a beautiful question. What are the conditions where you get repeated respiratory tract infection? Very simple question. Just use your basic common sense. What are the conditions where you get repeated respiratory tract infection in infancy? Can anyone answer in the comment section, please? Osama, Radhika, Manisha. Yes, very beautiful. Priya is saying, why failure to thrive? So when there is increased pulmonary blood flow, when there is increased upper respiratory tract infection, increased lower respiratory tract infection, so the patient's weight and height will be compromised, right? Dr. Priya, if example, Dr. Priya, you get admitted in the hospital within 1 month, if 3 times within 1 month, Dr. Priya, if you are admitting in hospital for 3 times, will your weight and height will be affected? Obviously, my dear, your weight and height, you will not be gaining weight and height with the beautiful full 50th centile, right, you will have a loss in the weight and the height because you are getting hospitalized too many times, you're getting recurrent pneumonias, right? So naturally you will be a case of failure to thrive. Failure to thrive means like you're on the two to three occasions of the hospital visits, your weight and growth chart will be below the normal centile. That is like failure to thrive. Exactly. Osama says पर्दे में रहने दो पर्दा ना उठाओ. Yes, that's true. True, true, true. What are the conditions where you get repeated respiratory tract infection in infancy? Very true. If I talk, yes, exactly. So very beautifully, everyone is saying. So we have the respiratory causes, we have the respiratory causes, we have the cardiac causes, renal causes, hepatic causes. Exactly. So the respiratory causes, yes. If a patient is a case of hyaline membrane disease, the patient can have repeated respiratory tract infection. If the patient is a case of meconium aspiration syndrome, definitely when the baby has taken too much of meconium in the mummy's tummy, in the lungs basically, the baby can have recurrent pneumonias, recurrent hyperinflated chest. But as we are talking about cardiology today, could you please tell me cardiac causes? Could anyone please tell me the cardiac causes of what you call repeated respiratory tract infection? I think we have done this before. Can I write ASD, VSD and PDA? Large ASD, PDA and ASD? Yes or no? Can anyone answer in the comment section, please? Exactly. Yes, very good. So the cardiac causes of repeated URTI, repeated LRTI are VSD, PDA, and ASD. But this is not the question. We have done this multiple times. I have a question. I have a question to say that if I have to arrange this in a ascending order, which one will be affected? Like which one is the commonest cause for increased URTI, LRTI, followed by dash and followed by dash? Is VSD more common than PDA than ASD, or ASD more common than VSD and PDA? Can anyone answer in a hierarchy wise ascending order of the cardiac causes of increase upper what you called URT and LRTIs? Exactly. Dr. Mariam Mumtaz is very right. So if I talk about a proper what you called designation of the symptoms, so yes, exactly. So the best answer for this one is obviously PDA. As we all know, in the four chambered beautiful heart, we have the patent ductus arteriosus over here. This one, patent ductus arteriosus. So naturally PDA will have kind of a repeated infection, repeated URTI, repeated LRTI. So from the pulmonary artery, PDA is the closest. So PDA is the first differential diagnosis, of course. Oh. Yes, Dr. Osama, you're very right. Yes, Vafa PDA will be first. Okay, Vafa PDA will be first because it's the closest to the pulmonary artery. That's why. Yes, perfect. That's right. Osama is right. Osama message. Apurva is right. Everyone is bang on right. Beautiful people answering amazing stuff. So yes, that's true. It is patent ductus arteriosus followed by VSD and followed by ASD. ASD always present later. Remember, hello everyone, listen very carefully. If someone asks you that in a congenital heart disease basically, and with repeated respiratory infection, repeated URTI, repeated LRTI, what do you think, or which shunt problem you think? Please say PDA first, then say VSD. If anyone saying ASD first, the examiner will not give you good marks. If anyone saying ASD will have a increased URTA, LRTA, ASD will present very late with the, are you understanding? So PDA is first, then the VSD, then the ASD. Always remember, jo marzi ho jaye. Has everyone understood this much? Dr. Mukesh, Dr. Priya, Manish, Radhika, Karan, has everyone got it? Now I have one more beautiful question. What are the other causes of repeated respiratory tract infection in the cardiovascular system? Can anyone roughly answer me any amazing answer in the cardiology? I know ASD, VSD, PDA, all are the left to right shunts, all are plethoric lung fields, all will cause repeated URTI and LRTI. Other than these three names, can you please tell me any other random name in cardiology where the patient can have repeated respiratory tract infections? Anyone? Yes. If you do wrong, you can guide. Yes, Dr. Wafa Hussain, very true. Yeah, because Dr. ABC, PDA is very close to the pulmonary artery. That's why PDA having showing you the symptoms of increased pulmonary blood flow are more common than the VSD, then the ASD, because whosoever is closest to the pulmonary artery will have more URT and more LRTI problems. Can anyone tell me any other important word of any congenital heart disease which can cause repeated respiratory tract infection? The beautiful answer is truncus arteriosus. Please remember, truncus arteriosus is a very important disease which can definitely comes to you as a cyanotic, as a congenital cardiovascular problem with increased pulmonary blood flow or repeated respiratory tract infection. You know, right? What is truncus arteriosus? Like if this is the four-chambered heart, if this is the four-chambered heart, so normally we have a pulmonary artery and aorta, but this like this, okay, this one. So this is nothing but a truncus, like two vessels connecting at one. This is a truncus. This is the truncus arteriosus. And I have a question here. I have a question here. Yes, Dr. Osama, very good. Even TAPVC also. Delete mat karo Osama, sahi jawab de raha tu. So TAPVC also, naturally supracardiac TAPVC. Can I say that supracardiac TAPVC can present as repeated respiratory tract infection? Yes or no? You know, right? TAPVC. What is TAPVC? Total anomalous pulmonary venous connection, right? Total anomalous means totally wrong. What is wrong? Pulmonary veins connection. If this is my lungs, then the pulmonary veins normally enter into the left atrium. This is normal. But if the pulmonary veins are getting connected into anywhere, if even in my superior vena cava, that will be known as a TAPVC. Like we have a detailed classification of TAPVC. I can't tell everything right now, but that's what you need to know. Okay, so I'll repeat again. The important important cardiology causes of increased pulmonary blood flow or increased respiratory tract infection other than PDA, other than VSD, other than ASD are truncus arteriosus and supracardiac TAPVC. Truncus arteriosus and supracardiac TAPVC. And I have a very beautiful question to ask here. Can you please tell me? Can you please tell me and any two congenital hearts which are duct independent? Tell me two congenital heart disease which are duct independent. What is the meaning of duct independent? Means tell me two congenital heart disease in which if I keep the PDA open, this one is the PDA. No, if I keep the PDA open, it is of no use. Very smart question. And let's see if anyone can answer. Dr. Manisha Osama. Okay, yes. Oh, Osama. High five answers. Yes, brother, you are very right, Osama. Very good. Your knowledge has tremendously increased, Osama. I'm really proud of you. Can you please answer my question? I have a beautiful question to ask here. Tell me two congenital heart disease where I keep the ductus arteriosus open is of no use. In nothing but I'm asking you, tell me duct independent congenital hearts. Yes, very. So Pooja says VSD and ASD. Okay. The best answer is, of course, is truncus arteriosus. Also, can I say truncus arteriosus, bro? It is a duct independent congenital heart. Are you understanding? No, because the pulmonary artery and aorta, they are like one vessel now. They are like one vessel now, right? So in this one big vessel, if I keep the PDA open, it is of no use. Are you understanding? Yes or no? Put a like button to this video if you're able to understand. I am saying that truncus arteriosus, you have a pulmonary artery, you have a aorta. If they are separate, keeping the PDA kind of will be helpful if I want the blood from the left side of the heart to go to the right side. Are you understanding? Like in the case of TGA, we know that transposition of great arteries is a duct dependent congenital heart. But in truncus arteriosus, the pulmonary artery and aorta, they are not separate vessel. They are like one single vessel. So in this one single vessel, if I keep the chotu sa PDA open, it is of no use, bro. It is of no use. So truncus arteriosus is the duct independent congenital heart. And also, as Dr. Osama said, supracardiac TAPVC, supracardiac TAPVC also is a duct independent congenital heart disease. Do you agree with this line? Yes or no? Supracardiac TAPVC is a duct independent, means in a case of supracardiac TAPVC, if I keep the ductus arteriosus open, it is of no use. Why, sir? Why it is like that? Because, my dear, that in the supracardiac TAPVC, supracardiac means above the heart, TAPVC means total anomalous, totally wrong. What is wrong? Pulmonary venous connection. So in the case of supracardiac TAPVC, the pulmonary veins basically they get connected into the superior vena cava. So when, are you understanding? So when normally also the blood from the superior vena cava goes to the right atrium, right ventricle, and the pulmonary artery. This is the normal flow. Whereas on the left side, the blood from the lungs, from the pulmonary veins enter the left atrium, left ventricle, and pulmonary artery. Are you understanding? So the whole blood is jumping to the right side of the heart. The whole blood is jumping to the right side of the heart. So in this case, if I keep the PDA open, I don't think so there is gonna be any help for the baby. Do you agree with this line? Yes or yes? डॉक्टर शुभम सेज सर आज सर जी आपकी चप्पल की याद आ रही है, आशीर्वाद है। यस बेटा, जान से मार दूंगा। गलत आंसर किया ना शुभम तूने बेटा। कौन सा शुद्ध वाक्य यूज करो मुझे नहीं पता, लेकिन हैज एवरीवन अंडरस्टूड दिस मच? यस और नो? प्लीज पुट अ लाइक बटन दैट यू हैव अंडरस्टूड, और जस्ट टेल मी अ यस और अ यस। हैज एवरीवन अंडरस्टूड दिस मच? यस और यस। समझ में आ गया सबको? यस और नो? कैन आई कंटिन्यू फर्दर प्लीज? मैंने पानी भी नहीं रखा आज, मैंने शेक भी नहीं पिया, कुछ भी नहीं पिया आज मैंने। आज डायरेक्टली आई केम टू द क्लास बिकॉज आई गॉट लेट। Has everyone understood? Put a like button, please. Are you able to get it? Am I making sense to you, my dear friends? I hope you have got it. Okay, beautiful. So let's quickly revise. Can we just quickly revise whatever we have spoken? So many things we spoke, okay, today in the today's class. So in this beautiful class, number one, sir, you told that number one, the most common congenital heart at day of one of life. I'm gonna do a very quick recap. In this class, we spoke that the most common congenital heart disease at day one of life is TGA. Then also we understood the tetralogy of Fallot cannot be a congenital heart at day one of life because TOF has a component of pulmonary stenosis, or if I say in a better words, it is progressive pulmonary stenosis. In a more better words, progressive infundibular stenosis. So it takes some time for the full pulmonary stenosis to happen because it is a progressive infundibular stenosis. So it will take time for the whole pulmonary stenosis and then the cyanosis and then the failure. That's why TOF is my second differential diagnosis for a cyanotic congenital heart in a baby. Suck, rest, suck cycle, we understood baby suck the breast basically. Sucking is like an exercise, and as I'm having a left ventricular dysfunction, if I need more energy for sucking the breast, so I'll become breathlessness due to LV dysfunction, and also I'll be sweating because of the sympathetic overactivity, and also because I have an increased metabolic demand of my body. Then also we understood that the symptoms, if I'm having an increased pulmonary blood flow, I'll have URTI, LRTI, what do you call, failure to, one second, URTI, LRTI, failure to thrive, not gaining weight, not gaining height, anything which affect the lungs, I'll have pneumonia, respiratory infections, failure, not gaining weight, not gaining height, I'll be a case of FTT. Then also we have understood that what you called the cardiac causes of increased pulmonary blood flow, everyone knows ASD, VSD, PDA, but if I put in a proper ascending order, then I think PDA is first, then is my VSD, and then is my ASD. This part is over. One very beautiful picture which you understood, that other causes, see, that's what, open your brains now. In your notes, in your in your notes now, can we update our knowledge? Can we broaden our picture of knowledge, that increased pulmonary blood flow or increased URT and LRTI? Yes, we all know it's PDA, VSD, and ASD, but then also it will be seen in a case of truncus, arteriosus, and TAPVC. Okay, that you should know. Okay, next question, please. Okay, and what is the mechanism? Now, can you please, if I am the examiner and has everyone understood, my dear friends? I hope everyone has got it. I hope everyone has beautifully got the whole picture, what I'm trying to tell you. 5 more minutes, and we're gonna finish this class today. It's the last class for today's week. Tomorrow is my night duty, and then Sunday a little off. Sunday we have a test on our Telegram channel. Tomorrow you will get a beautiful notification of our test, and the rupees 500 is the first prize. And if you are not what you call there in our pediatrics Telegram group, nothing, just go open Telegram and write pediatrics by Dr. Anand. Pediatrics by Dr. Anand. You will find the group. We have some 14,000 members. Just join the group, and automatically you'll get a notification on Sunday what time is the test, what are the do's and don'ts for the test, and the first prize is rupees 500. So it will be, you'll get only 15 minutes to enter that test. Okay, if, like example, if I open the test at 12 o'clock, 12:15 will close the test, and I'll tell you the whole schedule. Just be updated tomorrow on our Telegram channel. ओके, यस एग्जैक्टली। 9 नंबर चप्पल, मेरी भी 9 नंबर चप्पल है। गलत आंसर दे के दिखाओ बेटा, घर पे आके मारूंगा मैं। ओसामा एंड शुभम स्पेसिफिकली। Manish, yes. So, okay, and what is the mechanism? Can you please tell me? Now, this is a very smart question. Today, I was watching some amazing cardiology session of a huge pediatrician worldwide. They were telling a very beautiful point. Can you please tell me why there is repeated respiratory tract infection in a case of increased pulmonary blood flow? Why there is repeated respiratory tract infection? Can anyone randomly tell me a beautiful answer? Did you get the question? If I'm saying that there is increased pulmonary blood flow, if I'm saying there is an increased pulmonary blood flow, so basically like what is the mechanism if I'm having an increased pulmonary blood flow, why my lungs will be affected? Because number one, very important, whenever there is an increased pulmonary blood flow, pulmonary vessels get dilated. Okay, listen very carefully. Just tell yourself you're reading this topic for the first and last time. Okay, yes, Pooja is right. Congestion also is beautiful answer. Mariam Mumtaz, yes. Listen, think. Okay, relax, think, listen to me. Whenever there is increased pulmonary blood flow, naturally pulmonary vessels will dilate. Pulmonary vessels will dilate, right? So pulmonary vessels will dilate, and pulmonary vessels, and what is the down part we have? We have is the bronchioles. Naturally, we have bronchi and the bronchioles. So that will compress the bronchioles. Okay, I'll repeat again. Increased pulmonary blood flow, pulmonary vessels dilate, and it will compress the bronchioles. Number one. Number two, when it will compress the bronchioles, it will cause microatelectasis. It will cause, because bronchioles are getting compressed, so it will cause damage. Microatelectasis. Microatelectasis. Okay, number one. And as there is microatelectasis, naturally, when atelectasis takes place, then naturally all the inflammatory markers and phagocytes come over there to clear out the space. So phagocytosis takes place, which is not adequate. Phagocytosis takes place, which is not adequate. Listen very carefully, it's very beautiful explanation. The thing is, my question was, examiner is asking you why increased pulmonary blood flow will lead to URTI, LRTI, pneumonia, lung collapse. Why? Because sir, when there is increased pulmonary blood flow, pulmonary vessels dilate. Dilate is very important word here. Once they dilate, it will compress the bronchioles. Kind of, it will compress the bronchioles. I would say it will damage the bronchioles. So once it damages the bronchioles, it will lead to small collapse. Small atelectasis is collapse. So it will lead to micro atelectasis. And once some damage or collapse or damage happens, then we all know that our body has a defensive mechanism. All the inflammatory markers or interleukins or even phagocytosis basically takes place. But this phagocytosis which takes place, it is not adequate. It is not adequate. Once this phagocytosis is not adequate, so obviously the secretions or the collapses or the damage which is there, basically the mucus which is supposed to be drained out, that there's a stagnation of the mucus in the atelectic lung, stagnation of the mucus. And naturally, once the mucus gets stuck over there, it is like a nidus for the infection to grow. It is like a nidus for the infection to grow. So this is one reason why do you get increase URTI, increase LRTI for the in the case of increased pulmonary blood flow. I hope everyone has understood. Like with lot of pain and hard work, I have got these points. It might be looking very easy to you. हाँ पता तो है ये ऐसी तो होता है. But frankly, मतलब I it took me a lot of time to process. And okay, like this how it happens. As everyone, शुभम समझ में आ गया डियर तेरे को? ठीक है. Osama, did you get it, bro? So that's what. This is what I want you guys to remember. I hope you have got it. Next question, please. I have the next question. Okay, yeah. So now the mother says the baby is 10 months old, and now the repeated URTI, repeated LRTI have come down. Very simple question. This is also very important PG question. A 10-month-old child with congenital cyanotic heart disease, and mother says, doctor, there was previous lot of repeated hospitalizations history was there, doctor, but now the repeated LRTIs have come down. So now how do you approach this case? My question is this a good sign? Is this a bad sign? Or is this normal? How do you approach? Anyone? Dr. Shubham, mere bhai, Mariam, Grace, Pearls of Wisdom, Grace, Mukesh, Radhika, Mani Prakash, our Manish Yadav, Osama, कितने सारे लोग हैं? उफ, नाम बोलते बोलते थक गया. हाँ जी. Anyone? Shubhangi kहाँ है? Shubhangi, yes, exactly. Can you please tell me now how do you approach this case, bro? My question is like the mother says that 10 months old now all the URTI, LRTI have gone down. Exactly. Dr. Shubham has a very beautiful answer. Shubham says it is a good sign or a bad sign. As we all know, it is a bad sign. Why it is a bad sign? I think everyone knows about it. We have discussed this multiple times. When someone is having increased URTI and increased LRTI, Pearls of Wisdom says something is fishy, sir. Fishy only. Which fish? Is the tuna fish or is the piranha fish? Which fish exactly? The best answer for this question, listen very carefully. I think we have newcomers in this class also. Listen, guys, the question is repeated URTI, repeated LRTI have come down. Mother is very happy. How do you approach this case? The answer is it is a very bad prognostic or a very bad thing that URTI and LRTI have come down. Why, sir? Why URTI, LRTI has come down? Why it is a bad thing? So whenever there was upper respiratory tract infection and lower respiratory tract infection, I indirectly understand that there was increased pulmonary blood flow. Yes or no? There was increased pulmonary blood flow. That is why it was upper respiratory and lower respiratory tract infection the patient was having. And whenever there is an increased pulmonary blood flow, or whenever on a road when the traffic is too much, when the pulmonary blood flow is too much, that road starts going into damage. So that will lead to, very importantly, by time the patient will have pulmonary atresia, the patient will have pulmonary obstruction, the patient will have pulmonary stenosis, the patient will have a pulmonary arterial hypertension, nothing but there'll be total block like a pulmonary stenosis. In a case of what he called increased URTI and increased LRTI, there will be followed by it will be complete pulmonary obstruction. So the shunt which was left to right, now it is right to left, right to left. Very, very important. So now the URTI and the LRTI episodes will go down. It will go down. Exactly. Dr. Faizan Raza is right. This reversal of shunt is known as Eisenmingerization. I assume there was some left to right shunt, because naturally you increase URTI, increase LRTI, nothing but increase pulmonary blood flow. No, for increased pulmonary blood flow, then obviously some left to right shunt could be there. Could be a ASD, could be a VSD, or could be a PTA. Right? We are talking differentials here. But now there is reversal of shunt, and because the whole thing I have told you multiple times. So that is why the best answer for this question is repeated URTI and LRTI have gone down. What do you think? The answer is, sir, there is a reversal of shunt, and the answer is, sir, the pulmonary hypertension is developing naturally. The pulmonary arterial hypertension is developing. That is one point. And second point, and automatically respiratory tract infection will come down. Are you understanding? Pulmonary hypertension, pulmonary stenosis. So lungs are not available for increased pulmonary blood flow. So URTI, LRTI will go down, and cyanosis will develop. And I will say, but the child might be a candidate of inoperable case. Like the baby has gone so much it has gone to what you called a reversal of shunt, that the baby kind might be inoperable. Dr. Shubham, Dr. Shubham has written, okay, you have written the right line. TOF never show reversal of shunt. That's true. I agree with you. TOF with guy, I hope you know that in tetralogy of phalate, this reversal of shunt will not be seen. Reversal of shunt can be seen in a case of course, PDA, can be seen in a case of VSD, very less likely in a case of ASD. And in tetralogy of phalate, I hope everyone knows that you cannot see reversal of shunt, because the component which was there in tetralogy of phalate, which is ventricular septal defect, it is a right to left shunt. It is a right to left shunt. It was never left to right. That's what. So has everyone understood? Please put a like button. Did you get it, guys? Yes or no? Please let me know. Please let me know. समझ में आया कि नहीं आया? Yes, yes, yes. Hmm. Yes, okay, that's nice. Karan, समझ में आ गया, bro? Everyone got it? Can I continue, please? Let me know. ठीक है? See, cardio is like maths, okay? I'm really trying my best to tell you every single entity of cardiology, from this way to that way to this way to that way. Exactly. Can consider vitamin D deficiency as a cause of recurrent LRTI, causes hypocalcemia, impair muscles. Yes, Dr. Isra Mustafa, yes, you can say about the recurrent URT LRTI that there are respiratory causes for increased URT LRTI, like hyaline membrane disease, transient tachypnea of newborn, and what you called meconium aspiration syndrome. There are other causes like cystic fibrosis. Do you agree with me, guys? Can a patient of cystic fibrosis can come to you with repeated URTI and LRTI? Why? You know that, right? Mother, while kissing her child, found her child's skin salty tasting, and in cystic fibrosis also there is a stagnation of secretions. Okay, in cystic fibrosis also there is stagnation of secretions. Can I say cartilage syndrome? Yes or no? Have you heard anyone? Please let me know. Can I say that cartilage syndrome patient can have repeated upper respiratory tract infection and lower respiratory tract infection? Yes, because in cartilage syndrome, again, there's a problem with my cilia and there is a stagnation of secretion. So, 100 बात की एक बात ये है, the broad spectrum is the increased URTI, increased LRTI can be in multiple places like cystic fibrosis, cartilage syndrome, Young syndrome, respiratory causes like hyaline membrane disease, transient tachypnea of newborn, and meconium aspiration syndrome. But as we are talking cardiology, our answers are this. मैं तो चलो बस करते, थक गया मैं. एज एवरीवन, मेरे लैपटॉप की बैटरी भी डाउन हो गई, मेरी बैटरी भी डाउन हो गई, लैपटॉप की बैटरी भी डाउन हो गई. ओके, I think let's finish this class here. I think we have spoken enough today about it. I have some more crazy questions to ask you also. In the Monday class, we're going to talk about brain abscess, infective endocarditis, how the patient will present, and many other things. So has everyone understood this much? 60 minutes of class is almost over, and let me know if anyone has any doubt. Okay, yes, yes, yes. Very good, very good. Yes, that's right. Yes, very good, perfect. So समझ में आ गया सबको? I think let's end up this class here. Great, great. We're gonna finish this class here. We have in the further classes we're gonna talk about, like, I'm gonna talk about the TGA, TAPVC, Truncus, and TOF per se for sure. But we have to continue this case presentation where I'm gonna ask about other questions to you. If a patient has failure plus cyanosis, some crazy question I'm gonna ask you, okay, which will blow up your mind. But right now, as you know, is 60 minutes quick session, we're gonna end up till here only. Okay, 1 second. Yes, okay. Yes, okay. Yeah, Dr. Suman says thank you, sir, have some amazing rest. Pearls of Wisdom say thank you, sir, maza aa gaya. Faizan, yes. Faizan, okay. Okay. कौन सा गाना सुनाऊं? आज मैंने गाना ना, मेरे दिमाग घुमा हुआ है एक्चुअली, मैंने कुछ खाया ही नहीं है, इसलिए माय माइंड इज लाइक रोमिंग here and there. Okay, great. So today, like, what you called, okay, let's have a very quick any random song. Okay. कौन सा सुनाओ? Like, I have so many songs in my mind. Okay, it's any random song. Okay. तुझको देखा तो ये जाना, तू ही मेरी मंजिल है, सांसों के बिन शायद जी लूं, तुझ बिन जीना मुश्किल है, मौसम भी उसमें रंगता है, जिस रंग में तू आ जाए, तेरी सुबहें और शामें हैं मेरी पलकों के साए. So that was a small quick song which I know you have heard it, Dr. Shubham. Thank you so much everyone for this wonderful participation. Have a beautiful evening ahead, guys. Tomorrow, Saturday, Sunday, no classes. Sunday we have a test. Just be online on our Telegram channel. देखते रहिएगा उसको. Dr. Osama, do you have some amazing, beautiful quote to share with us? Yes. Thank you so much. And बिन तेरे मंडे को सुनाएंगे, मंडे को. मंडे को, बिन तेरे मंडे को. उसमें अलग अलग है ना, बिन तेरे, दो बिन तेरे होते हैं, आई टोल्ड यू राइट. बिन तेरे, बिन तेरे, एंड द अदर इज बिन तेरे, बिन तेरे, बिन तेरे कोई खलिश है हवाओं में, बिन तेरे है क्या ये जो तेरे मेरे दरमियां है। बाकी की लाइन मंडे को। Thank you so much, everyone. Bye bye. And yes, before leaving, Dr. Osama's quote has to be spoken. 1 second. Let me read. कि कोई गलती मुझसे हो जाए अगर, तो तुम्हारा एक माँ, अगर हम तुम ही नहीं हम- वाह, Osama, mind blowing. Okay, I have a nice quote Dr. Osama has shared. Okay, listen very carefully, and we're gonna end this class. Dr. Osama says that कि कोई गलती मुझसे हो जाए अगर, कि कोई गलती मुझसे हो जाए अगर, तो तुम्हारा एक माफ करना ही इस रिश्ते को बचा सकता है। कि कोई गलती मुझसे हो जाए अगर, तो तुम्हारा एक माफ करना ही इस रिश्ते को बचा सकता है। अगर हम तुम ही नहीं निभा सके एक दूजे संग, तो और कौन निभा सकता है। So very beautiful quote, very simple and very nice quote. I'll repeat again for the last time. Dr. Osama says कि कोई गलती मुझसे हो जाए अगर, तो तुम्हारे एक माफ करना ही इस रिश्ते को बचा सकता है। अगर हम तुम ही नहीं निभा सके एक दूजे संग, तो और कौन निभा सकता है। So very beautiful quote. I'm gonna pin this quote on our amazing class, and this quote has been pinned. Every Osama's quote is pinned in my classes. Thank you so much, everyone. Please take care and see you on Monday, 8:30 p.m. Monday timings I'll tell you, but see you on Monday for sure. Take care and bye.